Atsusi will turn the time over to you and take it away.
Okay, so I've hopefully shared my screen. Does everyone see my screen?
Yes.
Okay, everyone see the PowerPoint? It's PDF at this point. Yes, no? Yes,
Yes.
okay. Terrific. So thank you, Jason. As Jason mentioned, we've been friends for quite some time. I'm honored to be invited to speak here today. What I want to do is kind of give you the latest and greatest of what I've been up to. So about 7 years ago, I was invited to participate in a grant by the department chair in the College of, in the Department of Medical Education in the College of Medicine here at UCF. He had heard my work in instructional design and working with some healthcare facilities, and he had a $1.8 million grant to create virtual patient simulation for students in the school on how to diagnose patients presenting with cranial nerve disorders. And they've been working on it for about 3 years, but he was kind of disturbed that he didn't feel like it was very educational. And so when I looked at it, it was like a really cool simulation. It was like the doctors working with the engineers to create the simulation, and you could do this and you could do that. But then after about 20, 30 minutes, it was like, oh, well, so what? So they didn't have it. They had an educator at the beginning, but they didn't continue with that person for reasons I don't know. But it became apparent that they could use some instructional design. So I came in and it worked out very well. By the 4th year, I was directing the last year of design-based research to try to improve the product before it came out, and it worked out very well. So 2 years ago, no, now actually 3 years ago, he invited me to become a member of the faculty. So now I'm on joint appointment with the College of Medicine. So what I want to do is kind of present to you a design challenge based on what I'm doing right now. So 100% of the faculty recognize the need for evidence-based clinical practice. All responsible professionals should keep up and apply research in their discipline. And if you ask every faculty member in the College of Medicine, they believe in evidence-based medicine. In order to diagnose and treat patients, you should base your decisions on research. Terrific. The problem is the same standard does not apply to education. And here's some quotes that I've heard directly from faculty. There's none of this stuff went around in my days when I was teaching. I learned this way, so why can't I teach this way? Students don't know what they need. Medical education is very complicated. You don't really understand what we're trying to do here. And students don't pay attention to objectives. Why should I? Just a few of the comments that I've kind of recorded during the last couple of years here. So he gave me the challenge of hiring me the first year and said, you have to prove yourself. We're going to have you be part of our faculty for 1 year. I'm now on my 3rd year, so I'm doing okay, I think. But they have to really accept me as a faculty member, and we wanted to have a significant number of them wanted to actually work with me to revise and improve their coursework. So with that kind of challenge, I'm going to challenge you guys with this design challenge. So given an approach to design, and you could pick either one. You could pick from 2. You could pick the design studio approach that I'm sure you're familiar with. I know Jason is a big proponent and a leader nationally or internationally in use of design studios, and I respect Jason quite a bit for his work and use of design studios. I've learned a lot from him, actually, and it was kind of interesting. A couple conferences, we actually had a panel session on design research and the studio approach versus the systematic design approach, which I preach or lecture and teach everyone on. The Dick and Carey Addy model is what I teach here in Orlando. I've done so for the last 25 years. So you can pick either one, whatever you're familiar with or whatever you feel more comfortable with. And then some knowledge of evidence-based medicine and factors that affect the adoption of innovations. And I'm challenging you with describing how you would adapt your approach, either this design studio approach or the systematic design approach, to facilitate evidence-based medical education and retain your job. So I want you to pretend you've just been hired, like I've been, as an instructional design expert in the College of Medicine. And to retain your job, you have to get people to actually buy into your Kool-Aid, okay? So that's the approach, okay? So here are your givens. You can, again, pick either design studio features, the systematic design approach, either one of those two, okay? Did everyone get a copy of the factors affecting the adoption of innovations? So I tried to make sure everyone got a copy of that. If you didn't, this is what it looks like. So you want to understand each of these factors, because that's what I want to ask you to do, is how would you demonstrate relative advantage of your approach? How would you facilitate or enhance the compatibility of your approach? How would you adapt your approach to reduce complexity? How would you adapt your approach to increase trialability, modifiability, and observability? Okay. So what I want to do is I'm going to break everyone into small groups and have you discuss that amongst yourselves for about 5-10 minutes. And then we're going to proceed by asking you what you found or what findings you found within your small group, present that, and then I will present what I've been doing specifically over the last 3 years to come up with what I call a transdisciplinary model for advancing evidence-based medical education. Does that sound like fun? Sounds like quite a challenge?
Yes.
So, and one last thing before, this is the basic steps associated with evidence-based medicine. So assess the patient's need, ask PICO questions, which is ask questions about the patient, the intervention, the context, and the desired outcomes. So let me repeat that because that's kind of important. So the second step in evidence-based medicine is to ask and answer questions about the patient, interventions, the context, and the desired outcome. And then based on that, they acquire and appraise evidence, they apply evidence, and then they assess their application. So that is evidence-based, and they all subscribe to that. If you ask every single clinical educator that I've ever met at UCF or across medical schools now, they all agree that evidence-based medicine is important. What's interesting is when you ask them about evidence-based education, they're not as responsive, okay? So any questions on the challenge? Everybody okay with that? Okay, so what I'm going to do is I'm going to put everyone in breakout rooms. I see 8 breakout rooms. Okay. And I'm going to open these breakout rooms. You should all be assigned to a breakout room. Whoop. Popping back into the main room. The small groups that I was able to jump into looked like they were right on task, which is great. This is not an uncommon challenge. I would call it a macro level design challenge. How do you get faculty to adopt the model? But if you work in a university or work in lots of sectors, there's your challenge with getting them to value what you do, right, as instructional designers. So I would say this is definitely an authentic challenge that I've been confronting for the last 3 years, and I want to share with you what I've learned as well as hear some of your ideas. So does everyone see the PowerPoint again? Okay.
Yes.
Yes.
I think we got pretty much everyone back. All right, so I think we're continuing. So what I want to do now is go through each of the factors and ask you what your thoughts are. So just chime in whenever you have an idea on how to address each of these factors. So let's start with compatibility. Anybody want to share what they came up with in order to facilitate compatibility of your approach?
I'm happy to share something. As we were talking in our group, we felt like it would be easiest for the faculty to accept what we were teaching if it was familiar to them. And so we created a parallel between the ADDIE model and the evidence-based model that the faculty were used to. And we felt like using that comparison, that would increase the compatibility and make it a lot more likely for the faculty members to use it.
Excellent. Anybody else? Other ideas on compatibility?
We had a similar discussion. We were talking about seeing medical work as science or art. And, you know, if you see it more of a science, you have to follow the research and you have to, you know, go with the double-blind studies. And so the ADDIE approach model seems like you've got these steps you have to follow. And so you follow those steps and you'll get to a certain result. And so maybe that would be, that's evidence for why that would be compatible together.
Terrific. So this is what I did or doing right now. So just like you guys are saying, here's evidence-based medicine. I'm applying basically their terminology to facilitate evidence-based medical education. So instead of articulating patients' needs, we're articulating the educational needs. Rather than asking PICO questions, if you think about it, if you know the systematic design model, you do a learner analysis, you do a context analysis, you analyze the desired learning outcome. So we're asking similar LICO questions. These last 3 steps are very similar. It's just how they're applied. So I'll get into that in more detail, a lot more detail in a minute to show you specifically how we relate these two. But I think everyone's consistent in saying that we want to use the same language to be more compatible with their practice. So that's great, okay? Right, so how about relative advantage? How would you demonstrate the relative advantage of following either the systematic design method or the design studio method versus what they've done in the past, which is what I call the subject matter expert approach? I teach this way, I learned this way, so I'm going to teach this way. So what's the relative advantage of what we preach or what we try to get people to do? Any thoughts?
I would say that because medicine is very much research-based and we rely a lot on research, showing them specific data or the research related to educational benefits for what you're trying to accomplish or why you're using the ADDIE model.
Okay, so what would be the relative advantage then of doing that?
We talked about how they have a potential of wasting their $1.8 million grant here on a deliverable that won't actually teach anyone, but is a cool simulation.
okay? But they're designing that simulation because they think it will teach people that, right?
We talked about creating, like getting a few teachers, probably newer teachers that aren't quite as ingrained in the culture, and having them agree to kind of help you, let you redesign a couple of their lessons, or let you help them redesign a couple of their lessons. That way they can see the outcomes and see what it does for their students, and then they can be advocates for your system.
There you go. Yep, start small, get a few people, and that's exactly what I did. I got 3 people, 3 faculty members to actually buy into this and try it out, and then hopefully they will be able to spread the relative advantage. Here's one of the things that I do. So I try to make sure that they see the relative advantage of systematic design is it ensures quality. So one of the things that we know is a problem with a lot of coursework that subject matter experts do is there's this lack of alignment between objectives, instructional strategy, and assessment. Medical school students are inundated by resources. So they get tons and tons of content, reading. You might have heard, or if you ever worked in a medical school, that's what happens. Students have to memorize all this stuff without clear objectives that help them distinguish what's nice to know versus need to know. There's often a lack of alignment between the assessments, which is primarily multiple choice. So if you work in a medical school, you know that the primary summative evaluation as well as their board exams are a multiple choice. Well, if they're trying to teach students higher order thinking skills and clinical reasoning skills, but their final exam is all multiple choice, you don't have this alignment that's so important. So I call this the horizontal alignment within a course as well as across courses. And I tried to emphasize that if you follow this systematic process, you will achieve this alignment. That's why we follow systematic design. We also have a vertical alignment between the objectives and competencies, the instructional strategy, which includes the content, right? Instructional strategy includes the chunking and presentation of content, the alignment of learner assessments within courses to professional licensure, and the alignment of all this with research theory and practice. So I try to focus on relative advantage. The quality of their instruction will increase, and hopefully the student learning and satisfaction will increase. I also talk about time. If you follow this process, especially with COVID, right, with pandemic and everything going online, you probably know as instructional designers that all the design flaws, like unclear objectives, right? It gets amplified online because you don't have an instructor live to explain what they're trying to teach. So all these design flaws, such as misalignment between the content and assessment, a good instructor will overcome those flaws by providing immediate feedback in class. What am I supposed to learn? Is this important? Is that important? Well, all those problems are amplified. So again, the relative advantage here is time. If you are online or facilitating learning, you actually reduce the amount of logistical questions. So then you could address higher order critical thinking skills and that kind of stuff. So that's the 2 pieces that I try to emphasize when I talk about the relative advantage of these methods. But like as one person mentioned, you actually have to have them do it and experience it to actually get them to believe it. So that's what I'm doing with relative advantage. How about complexity?
I could speak up on this one. This was the essence of what our group discussed. Myself, Teresa, and James, and Dr. West was with us. But we talked about this idea that there's a sort of cognitive load for some to understand instructional design and the sort of solutions that we bring. And we talked about how helpful it can be to rapid prototype with a wireframe or a proof of concept to show in a way that is specific to that individual how something is not as obtuse or mysterious or whatever as they may misunderstand it to be, that in fact, oh, I see what you're doing. I see what you're saying and what sort of value you can provide me. And this is exactly what I need. So that was a way that we kind of approached this one.
It's interesting that it's actually what you just talked about is what I do here in terms of relative advantage with time. You see, this is the model that I'm trying to get them to adopt, right? This is how they apply evidence. This is how I transformed what we do in terms of instructional design, learner analysis, context analysis. Cognitive task analysis is breaking down the outcome into subordinate skills and knowledge, right? So that's what these analyses are. And I'm trying to show them the relative advantage of, look, if you have an instructional designer, we can do all this stuff. So all they really have to do is help articulate the curricular needs. They have to have some input on some of this other stuff, that's lightly grayed out. But really, the instructional designer can save them a lot of time by doing a lot of this work for them or with them. I think that's what Michael was showing. You're like, we can do this. Here, let me give that to us, and we'll show you how this works, right?
Yeah, that's great. Thank you.
So in terms of complexity, you guys might not know the evidence-based medicine approach as well. But one of the things that I help them do is this acquire and appraise evidence. So in evidence-based medicine, they actually have a database. It's called the Cochrane database, where they could get all these data about evidence on medical practice. Well, we don't have that in education, right? We have lots of research out there, tons of research. So one of the challenges is, how do you decrease the complexity of finding evidence, acquiring evidence? How do you reduce the complexity of appraising evidence? So what I did is I broke down the potential areas, the domains of evidence, into three primary categories. We have research on how to facilitate the achievement of different learning outcomes. We have research about different learning theories. We have a lot of research about different instructional approaches. And so I tried to reduce the complexity of acquiring evidence by saying, here are three different domains that you can look for evidence. Our help you do it, but it helps them go, oh, because there's such a plethora of educational evidence, they have no idea where to go to find that evidence or how to organize the knowledge of evidence. I've also tried to reduce the complexity of appraising evidence because their method of appraising evidence has 6 different dimensions. It's this quest approach, and that's kind of codified in medical evidence. How do you appraise medical evidence? They have 6. Well, in my opinion, I think that's too complicated. I really believe in parsimony, the smallest number of factors to address the greatest variance. So I'm trying to reduce the complexity of people evaluating educational evidence by saying, look, let's look at this 3 fundamental factors when you appraise evidence. So those are 2 specific ways that I'm trying to reduce the complexity of acquiring and appraising evidence. So here's another way of looking at it. Here's the domains. Here's a sample of research studies to show people how there's research in all these different areas. So these are just examples of published resources in the medical education literature that talks about outcomes. Here's some published resources that talk about different learning theories and what's the evidence behind that. Here's some research that looks at different variables that affect the effectiveness or is correlated to the effectiveness of different instructional approaches. I've also given them these handouts, and I'm going to give you a copy of these handouts because I found that they really help as I do this. This is my Reader's Digest version of learning theories. So I'm going to make sure you guys get a copy of this. A lot of people appreciate the synthesis. So I've broken it, learning theories, down into 5 basic movements. You all heard of behavioralism, I'm sure. You all heard of cognitive movement, cognitive information processing, cognitive constructivist. Now we have neurobiological, and we also have the science of learning, which is very popular, which is more of a multidisciplinary approach to explaining how and why people learn. So this is a handout that I've kind of made summaries of each of these approaches that I distribute to faculty that are engaged enough to want to know about different learning theories. So again, I'll give you copies of all this after this session. I also have this nice handout on grounded events. So I give full credit to Smith and Reagan. I don't know if you've seen the Smith and Reagan design book, but they've actually analyzed all 50 years of research up to the 1999 and say these are the different techniques and approaches that are associated or correlated with facilitating verbal information learning. These techniques have been correlated through research to facilitate concept learning. These techniques have been shown through research to facilitate the learning of procedures or principles. So there's evidence behind each of these practices to facilitate these learning outcomes. So I call these grounded events. So that helps them distill the evidence and go, oh, research has shown if I'm going to try to teach someone a cognitive strategy, these are the kind of things that I should consider in my designs, as well as attitudes and psychomotor skills. So Pat Smith and Tim Reagan did a great job synthesizing this stuff in their book. I just put it all in one document so they don't have to look through a whole textbook. The one other thing that I have done or to facilitate this idea of design requirements. So the outcome of this appraising evidence is design requirements, right? So if you look at this process, you have these design requirements. So after appraising evidence, you come up with design requirements, and these requirements guide your design, okay? That's the logic. So in order to help with that, distill the requirements, I've come up with this document, which looks at all these principles that have been published associated with behavioralism, cognitive information processing theories, cognitive constructivist theories and approaches, neurobiological approaches, and the science of learning. So in this document, you will find principles. This is behavioral learning principles, published by Reeves and Reeves. Here's some cognitive information processing design principles. You probably heard of the multimedia design principles that comes out of the research from Richard Mayer. And so I've compiled all these. This is a great compilation of experiential learning principles. So I consider all these principles to be design requirements, or can be changed into design requirements, where learners apply this, or instructional designers apply these principles during the design process. So this is just another handout that I give to people as they try to apply this evidence-based method. Okay, so anybody want to talk?
Atsusi, we are about out of time. So can you just give us like your highlights of the last couple of things in the next 45 seconds?
Sure. So trialability, modifiability. I don't get people to try to do the whole thing. Okay. So when I start with this, I just start by saying, let's align your assessments. So I don't ask them to do the whole model. I found that's just way too overwhelming for medical educators, especially clinicians who actually have clinical practices going on. So maybe I just have them align assessments first. to their objectives. Then I could talk about how their objectives need to be redesigned. Or maybe I help them formulate a strategy, or I will try or get them to do one of these steps, and then more and more and more as I go across. In terms of observability, I'm trying to develop these use cases. So again, examples of how this will help. So I'm trying to get people to help me generate, and I'm going to invite all of you, if you want to, help design some use cases. So if you want to use this model and you're interested in this model, please contact me and we'll come up with some use cases. And I figure if I have a database of use cases, then they could see how this approach can be applied. So what I tried to do in an hour is kind of give you an authentic design challenge, gave you some givens, right? Which is exactly what I've been given to work with, and talk about how you could adapt either the design studio approach or the systematic design method to demonstrate compatibility, relative advantage, complexity, and address each of these factors to try to facilitate your work within a faculty or a college. And
Wonderful. Thank you so much, Atsusi. Let's thank him for the time and effort that he put into this seminar. It was wonderful, very insightful, very educational. Thank you so much for that. I wish we had time for questions, but alas, we do not. Our seminar is over. Atsusi, if you could turn the hosting back to me so I can then pass it to the next student who'll be beginning the next, the 1 o'clock activity here.
Sure. So I will give.
And if you are interested in, taking him up on his offer to participate, I can get you his contact information, and I'll also pass out. He'll send to me the flyers and handouts, and I'll make sure those get to the students as well. So thank you.
Okay, how do I give you back the hosting?
So in the participants panel,
Yep.
find my name. I should be near the top.
Yep, you're co-host.